I think that researchers themselves could do a better job of trying to explain to the public what it is we do. So first of all, I would like to say that we need to do more of this. And I think that the public, if we take the time to do that, we'll have different viewpoints, of course. We're in a heterogeneous and diverse society. But unless we do more of that, we can't say that the public is misperceiving if we don't give them the information to evaluate. I think that there are many elements that we can explain and speak less in a scientific jargon and actually work with communication specialists, frankly, to get messages out in different languages and in different at different levels. You know, why not let fourth graders hear about what we're doing at the level of a fourth grader? University students, medical professionals have different ways of communicating with the different constituents in society. There are many organizations now that, because the public votes with their checkbook, in other words, their taxes, and the people they elect, we have to go to the public. And particularly around public-private partnerships that we want to build from the private sector with civil society and with the public sector, we need to be out and to say, you know, what it is, you know, what our core values are, what our mission is, what we can do to be part of the solution, not to take on the whole problem, and to build these partnerships with the public sector. I am worried that there is mistrust between the public and academia and with public entities as well, but particularly with the pharmaceutical industry. So we have many corrective actions that we've taken. We are trying to respond and get feedback on what type of activities we need to improve ourselves on. But I would like to see us on a much more positive trajectory where it is clear that what we are doing is delivering what the public wants, the diseases they want us to work on. And the public has a lot of voices as well, so we can't satisfy all of the needs, but you know, certainly we want to be serving medical need in the way the public regains confidence in what we do. I think that many of the issues that the public has with pharma, we need to listen to, and we need to understand those what their issues are, and we need to have an iterative dialogue with the public about these things. When that happens, you know, we need to negotiate a path out of that. So I think, you know, part of the distrust was around transparency around data and publication of that data, and frankly the safety of our medicines. When we explain the safeguards that we do and the fact that we're a very highly regulated industry, more so than most industries, and get out with what we're doing to show that we've heard what they've said to us, and then what our plan are, and then to ask them, is that what you had in mind about our corrective action? The other thing we can do is just talk about the great science we do, about the lives that are affected by our medicines and our vaccines, about the programs that we build, the disease elimination programs, the health management programs around our therapeutics. Because it's not just about the molecule, it's not just about the vaccine, it's about the disease management programs that we build into this. Telling the story, asking our customers, our constituents, you know, how are we doing? Getting feedback, changing course, and I think that. So you know, I don't look at the public as having a misperception of us. I look at our need to have more of a dialogue with the public and to evolve. Science is about evolution anyway, so as scientists we should evolve with the public. Personally, I'd like to see progress in infectious diseases because you know, we have HIV is still a raging pandemic. Now, it's not thought about as much in the developed world because in many pharma and public-private partnerships working with the NIH and other public entities, we now have turned HIV in the developed world into a chronic disease. It is very treatable, not with the best, not with optimal medicine, so we still have room to go. But the largest part of the planet with HIV until recently had no access, and now We were making great strides with the Global Fund, PEPFAR, other programs that originated out of pharma to get into some of the issues around access. So, but there are two, three, four, five after HIV. So tuberculosis, malaria, acute respiratory infections in children, etc. That really deserve as much attention, I think, as HIV. So I wouldn't want to say one thing. I would say let's have a grander vision and tackle the top 10, at least the top 10. Trachoma is a historical disease. It's mentioned in the Greek papyri, and it's actually mentioned in the Bible. And it was in the U.S. In Appalachia and on the Indian reservations. After the Battle of the Nile, when basically Nelson sank the French fleet, the returning Navy and soldiers brought trachoma to Europe. So this has been a disease of the developed world. But with improved sanitation, the disease has gone away, and actually on the Indian reservations with some mass antibiotics. So until the poverty agenda and the North-South divide is really solved, trachoma is going to be a disease that requires other modalities, including antibiotic treatment. But again, I believe that with the current mobilization that disease is within reach. Trachoma is caused by a bacteria. It's usually crowding and in poor conditions, and with repeated infections of the eyes, scarring occurs over many years that leads to blindness. Malaria is a mosquito-transmitted disease, and actually, again, the South, all the way up to Washington in this country, was endemic for malaria. But today, 90% of malaria and malaria deaths are in sub-Saharan Africa. And again, the parasites have the advantage because of their sheer numbers and replication that they become quickly resistant to many of the available drugs. I believe with trachoma that the global elimination of trachoma is within reach by the year 2020, and that is our goals. I'm going to the World Health Organization tomorrow evening to be part of that annual meeting. That program is being linked with other neglected tropical disease programs that, again, many people in the field have been working on it, but for about 50 cents a year, with 4 or 5 already approved medicines, we can look at 8 or 9 neglected tropical diseases and imagine and actually set metrics around elimination. That's different from diseases like malaria, where frankly resistance is some of the biggest concern, and we really do need a full pipeline from early discovery to full development to address the continuing evolution of resistance. The parasites have the advantage. There will always be a need for new therapeutics until we eliminate malaria, but I don't see elimination as a real viable strategy for malaria right now. Very often, these are bacteria, viruses, or parasites that were formerly completely susceptible to a therapeutic. Many people don't. So one such bacteria is MRSA, and people hear about it in the news, which is methicillin-resistant Staph aureus. When Fleming first discovered penicillin would treat Staph aureus. That didn't last very long. Other agents have been synthesized, including different penicillins, completely new classes of agents, and I would say now that Staph aureus is pretty well served. So what I would expect would be there'll be a lack of further discovery and development for Staph aureus, and maybe in a period of time, 5 years, 10 years, or 15 years, we'll be back to the problem of not having agents for Staph aureus. Right now, we have gram-negative organisms, so these are bacteria that are found in water supplies, especially in hospitals because of the antibiotic pressure there, where, again, if you were to get infected with one of these organisms, there may not be a therapeutic that will have any effect against those organisms. These are the super-resistant bugs that you asked about. In New York City, just to make the case locally, In the late 80s, early 90s, there was relaxed control of tuberculosis. And so that patients would be admitted with tuberculosis to the hospital for isolation and therapy. After 2 weeks would feel better, but they need 6 more months of therapy, would be sent out. They would often get disorganized because they were from the inner cities or actually had mental illness. And this would happen 3 or 4 times until they developed multi-drug resistant tuberculosis, and in the layman's jargon, a super-resistant bug. And this was frightening. This situation is now playing out in places like South Africa, where they have something called XDR tuberculosis. And so I know I had many patients, I had many, and these epidemics would have outbursts in clinics and hospitals. So I knew healthcare providers that were infected and got sick. Sometimes both the patients and the healthcare providers were HIV positive. That seemed to promote actually the aggressiveness of the bacteria progressing in these patients. So it was quite a frightening situation. One of the good things about international travel now is that people are more aware of cultures and environments because they're traveling on business to emerging markets and frankly even some of the less developed countries. So I think that in general what globalization has brought is a more awareness of some of the inequities, not just with poverty but with diseases. And I hope with some of the economic trouble in the developed world that we don't lose sight of the fact that in the developing world they are suffering much worse than we are. So that we have an obligation in the developed world to not lose focus on international development issues. In the 70s, when Nixon announced the war on cancer, budgets were decreased for infectious diseases, and this has been well published and talked about in both the scientific and the lay press. And look what happened: HIV, multi-drug resistant tuberculosis, West Nile virus. I think we've responded now. What we can't do is relax our surveillance for emerging diseases, our laboratory capabilities to study these organisms, and then to scale up to have useful either therapeutics or vaccines. When SARS hit, and then people probably have forgotten about SARS, it was terrifying what happened, and it was like an influenza type of illness. The company I work for actually synthesized 65 compounds in less than a year in a very much of a Manhattan Project-like environment. To then the disease went away inexplicably. So I think that capability to quickly respond, and also I'm a firm believer in science evolving and new technologies becoming available. So wouldn't it be nice, and actually we are working on this technology, to have a vaccine response that takes weeks and not nearly a year in some cases. And so there are approaches, and we are working in that field as well. So it's about having existing capabilities and not relaxing the guard, both on surveillance of new diseases, but also the ability to respond.